time. So on to the question number 71. They are asking about a 56 years old woman comes to the office with her daughter to discuss the knee pain, which has been ongoing for several years. The patient has a high tolerance for pain and has previously refused to see a doctor for her condition. Okay. Lately, the pain has been affecting the patient's daily activity, and she spends most of the day sitting in a chair. The knee pain and stiffness are more pronounced on the right side and are worse in the morning but gradually improve by the afternoon. She takes no medication. Review of the system is positive for fatigue. The vital signs are within normal limits. The BMI is 31 kg per meter square. The lower extremity examination shows that both the knees are swollen and tender, but more so in the right side. The patient is unable to fully flex or extend the right knee. There is mild bilateral atrophy of the quadriceps. Radiographs of the knee reveal osteopenia of the distal femur, multiple periarticular erosions, and soft tissue swellings. Which of the following is best long-term management for the most likely diagnosis in this patient? And the options are antifolate immunosuppressants, the knee braces and the weight loss, systemic glucocorticoids, topical knee replacement, or the urate lowering therapy. And the answer choice is option alpha, that is antifolate immunosuppressant. Educational objective of this question is stating that clinical findings that favor the diagnosis of rheumatoid arthritis over osteoarthritis include prolonged morning stiffness, systemic symptoms, and soft tissue swelling. Other characteristic findings in the rheumatoid arthritis include the periarticular erosion on X-ray, elevated inflammatory markers, and positive cyclic citrullinated peptide antibodies or rheumatoid factor, disease modifying anti-rheumatic drugs, for example the methotrexate, slow disease progression and should be initiated on diagnosis. The discussion has a table which is giving us a differential between osteoarthritis and the rheumatoid arthritis. For the osteoarthritis, the age of onset is more than 40 and increases with age. The joint involvement is knees and hips, distal interphalangeal joint, and first carpometacarpal joint. Morning stiffness will not be present. If present, it will be brief. Systemic symptoms are absent. Examination shows hard bony enlargement of the joints. X-ray will show narrowed joint spaces and osteophytes. The rheumatoid arthritis, uh, the age of onset will be 40 to 60 and often in the younger patients. Joint involvement will be the metacarpophalangeal joints, proximal interphalangeal joints, and the wrist joints. Morning stiffness will be prolonged. Systemic symptoms are fever, fatigue, and weight loss. Examination shows soft, spongy, warm joints. Then X-ray shows periarticular erosions. The two most prevalent forms of the osteoarthritis are rheumatoid arthritis and individuals may have both conditions. The two most common forms of arthritis are osteoarthritis and the rheumatoid arthritis, and the individuals may have both the conditions concurrently. Osteoarthritis is much more common and characteristically involves the knees, hips, and distal finger joints. Rheumatoid arthritis and inflammatory arthritis typically involves the metacarpophalangeal, proximal interphalangeal, and wrist joints. However, any joint may be affected. This patient has multiple clinical and radiographic features suggestive of the rheumatoid arthritis. Her prolonged morning stiffness, systemic symptoms, for example fatigue, and soft tissue swelling involving multiple joints are more consistent with the rheumatoid arthritis than osteoarthritis. She also has X-ray findings that favor the diagnosis of rheumatoid arthritis over the osteoarthritis, including the periarticular erosions seen on her hand X-ray and distal osteopenia and soft tissue swelling. Additional evaluation of the patient with the suspected rheumatoid arthritis should include the inflammatory markers, for example, ESR, that is erythrocyte sedimentation rate, and C-reactive protein, which are typically elevated in the rheumatoid arthritis but normal in the osteoarthritis. Cyclic citrullinated peptide antibodies are present in most patients with the rheumatoid arthritis and can help confirm the diagnosis. Rheumatoid factor should also be tested but has lower specificity. Initial management of the rheumatoid arthritis include non-steroidal anti-inflammatory drugs and systemic glucocorticoids, for example prednisone, to acutely reduce the pain. However, these interventions do not alter the long-term prognosis and are inadequate for definitive therapy. As soon as possible after diagnosis is made, disease-modifying anti-rheumatic drugs (DMARDs) should be initiated to slow the disease progression. First-line options include methotrexate, a folate anti-metabolite that is cost-effective and well tolerated by most patients. Alternate options include sulfasalazine, leflunomide, and hydroxychloroquine. The choice beta, that is knee braces and weight loss. This is not the option of choice because Non-pharmacological intervention of the osteoarthritis include regular exercise and weight loss. Knee braces may reduce the pain in some patients but are unlikely to alter the long-term course of the condition. However, none of these interventions are adequate treatment for the rheumatoid arthritis. The choice delta, that is the total knee replacement. The total knee replacement is not the option of choice because the total knee arthroplasty is most commonly performed for the patient with advanced osteoarthritis. It is occasionally needed for the patient with severe deformity due to the rheumatoid arthritis, but early initiation of the DMARD therapy may eliminate the need for later joint replacement. The choice eta, that is urate lowering therapy. This is not the option of choice because urate lowering therapy is indicated for the long term treatment of the gout. Gout commonly affects the knees but typically causes episodic symptoms with brief but severe inflammatory changes, for example, redness, warmth, and swelling. X-rays in the early gout are generally normal, although chronic findings include punched out erosions with an overhanging rim of the cortical bone, that is rat bite lesion. The next question is question number 72, and they are asking about a 33 years old postpartum woman is brought to the emergency department with sudden onset of severe dyspnea and right-sided chest pain. Sudden onset of severe dyspnea and right-sided chest pain that began 3 hours ago when getting up from breastfeeding her child. The patient was discharged from the hospital 4 days ago after an uneventful elective cesarean delivery. She does not use tobacco, alcohol, or illicit drug. Temperature is 36.7 degrees Celsius and blood pressure is 100 per minute. No. The blood pressure is 100 by 70 millimeters of mercury. Pulse is 128 per minute and respirations are 32 per minute. Pulse oximetry is 84% on room air. The BMI is 34 kg per meter square. Examination shows a woman in moderate respiratory distress with evidence of accessory muscle use. She is alert and cooperative without cyanosis or jaundice. Her heart sounds are normal. The chest is clear to auscultation. Chest X-ray reveals no infiltrate and heart size is normal. ECG shows sinus tachycardia. Arterial blood gas analysis results are as follows. The pH is very alkaline, that is 7.52. It is high pH. The PCO2 is low. So the pH is high, but the PCO2 is low. Then we have PO2, that is also low, that is 55 millimeters of mercury, and bicarbonate level is kinda normal, that is 22 milligrams per liter. In addition to supplemental oxygen therapy, which of the following is the best initial step in the management of this patient? The options are: option A, CT angiogram of the chest, D-dimer testing, intravenous heparin infusion, lower extremity venous ultrasound, transthoracic echocardiogram, troponin and CKMB testing. And the answer is option Charlie, that is intravenous heparin infusion. Educational objective of this question is: early and effective anticoagulant decreases the mortality risk of acute pulmonary embolism and should be initiated prior to pursuing confirmatory diagnosis testing in the patient with likely probability of acute pulmonary embolism, especially those in moderate to severe distress. So now there is a flow sheet diagram. Approach to patients with suspected pulmonary embolism. Stabilize the patient with oxygen and IV fluids. Evaluate for absolute contraindications to anticoagulation. If there are absolute contraindication, like if they are present, absolute contraindications are present, obtain the diagnostic test to evaluate the pulmonary embolism. Positive for pulmonary okay, if the patient is positive for pulmonary embolism, consider the IVC filter. If the patient is negative for pulmonary embolism, no further evaluation is needed. Then if there is no absolute contraindication to anticoagulation, assess the clinical suspicion for pulmonary embolism with a modified Wells criteria. Pulmonary embolism is unlikely. Obtain the diagnostic test to evaluate for pulmonary embolism. Positive for pulmonary okay. And if the pulmonary embolism is likely, consider the anticoagulation, especially if the patient has no relative contraindication and moderate to severe distress. Then in both the conditions, obtain the diagnostic test to evaluate the pulmonary embolism. If the patient is negative for pulmonary embolism, stop the anticoagulation. And if he is positive for pulmonary embolism, start or continue anticoagulation. Consider surgery or thrombolytics if needed. Okay, so we will. It is a short session. We'll keep it till here, and then in the next session we'll continue the discussion of this question. Until then, Allah Hafiz, fi amanillah, and take care.